So first of all, in terms of symptoms, what are the signs of autism as such? You have the inability to sort of relate to children or adults, speech difficulties, inappropriate laughter and crying. And this is very important when one's actually looking at comorbidity assessments. And then you have oversensitivities, you have inappropriate playing as such, difficulties in dealing with changes in routine, and being oversensitive and possibly undersensitive depending on sensory issues as such. And this is a very, very simple way of trying to understand autism as such. When you look at the ICD-10, you have various things in terms of childhood autism, atypical autism, Rett syndrome, and other disintegrative disorders. The two in red are the bits that have been removed from the DSM-5 and have been placed separately. Unfortunately, those are the ones that I see in my clinic most of the time because I run a clinic for rare diseases, so I see a lot of Rett syndrome and disintegrative psychosis. So, in terms of the DSM-5 criteria, you basically have a combination of the social communication and the language difficulties have been combined together, and you have the restricted repetitive patterns of behavior as the second part of the difficulties. And here, what is really important to remember is that the sensory issues, that's the hyper or hyposensitivity of sensory issues, have been added and given a primary position within the context of the DSM-5, which was lacking in DSM-4. And on top of that, what DSM-5 has allowed is to add an accompanying specifier to let you know whether the person's got intellectual impairment, language impairment, whether there's a genetic or an environmental factor associated with it, or the association with other behavioral disorders. And lastly, whether you've got an association with catatonia. And this is important because quite a few children with, or adults for that matter, with ASD present with catatonic symptoms when they are under extreme stress, which often gets wrongly diagnosed as being schizophrenic. Now, gender and ASD, this is very important, especially when you're looking at it from the perspective of high-functioning individuals. Most of the time, girls are able to camouflage social communication difficulties, if they're high-functioning, much better than boys. And that's been more recently looked at as to why this is the case. And it seems that there are slightly different sort of cognitive processes going on in high-functioning boys versus high-functioning girls, or males and females. And what's really interesting is that you have higher verbal abilities in males, while you have executive functions are better in females. So therefore, they seem to be able to mimic social interactions, and so therefore girls or females get missed in terms of high-functioning ASD. And so where does one actually look for these individuals as such? And most of the time, they are actually lost in eating disorder services. They're in borderline personality disorder services dealing with borderline individuals, and also they are sort of lost when they have severe multiple anxiety disorders together. They are the places where if you want to really look for high-functioning ASD in females, these are the places that one has to be looking for rather than expecting a neurodevelopmental disorder service to find these individuals coming to them. Now, looking at genetic risks as such for ASD, there were millions and millions pumped into it, assuming that you'd be able to identify the single gene that's going to explain everything. Unfortunately, that's not the answer, and the most of the genetic risk is actually by the common genes that are the commonly inherited genes. So it's very difficult to actually be able to pinpoint and say you've got an answer that's going to be very simple to understand. Now, in terms of early detection of ASD, this is really fascinating because children as young as 6 months old, they start in terms of eye fixation. And this is by Ami Klin's group. And what they've done is actually just showing a small film with the presenter who all the children seem to like to look at. And what they've done is they've actually followed where the eye gaze is of the baby when they're looking at the face. And what they find is that you have those who are high risk to have autism or develop autism are the ones who look at the mouth, and the ones who are normal are the ones who look at the eyes. And so you can see this is the normal ones where all the focus is on the blue things, which is on the eyes, while here you can see most of it is on the mouth here in the red. And so what is really striking is that there is a fascination for, even in terms of the face, it's to do with trying to decipher aspects which is more like just simply, it's just pieces of information, but it doesn't seem to gel to look at it as a human. And if this is present as young as 6 months old, you can imagine how the impairment starts very early on. Now, this is the other very significant group, is to do with low birth weight. When children are born prematurely, you have a significant risk in terms of developing ASD, an autism spectrum difficulty, and social communication difficulties, social perception in children born with very low birth weight is impaired. So, and then there's the other aspect of it is when there is severe trauma and severe neglect in very early life, like for example the Romanian orphans as such, who've been adopted into other families, they have very high rates of ASD and ADHD symptomatology. And so some of them sort of view this as a quasi-autism state because some of the symptoms get better. However, long-term studies show that symptoms still continue to be present and they are impaired even after 20 years or so after having developed the problems have been identified. Now, coming to an assessment within the perspective of a clinic, these are the kind of forms that are now being used by parent groups who actually are working together to identify their children. And these are the kinds of symptoms they have, and there are multiple of them. So what happens is that the parent actually reads through that and ticks these things to say, my child has got this, my child has got this, my child has got this. And it's a very, very simple screen that is, and I'm not talking about this being diagnostic. This is to give you a screen that a parent a parent and a teacher, for example, has got control over in very young children. Now, when it comes to true screening, the purpose of screening is the presumptive identification of an unrecognized disease or defect by the application of tests. That is the perception of the thing screening. And the reason about screening has become a big issue because people are starting to wonder whether ASD is increasing in incidence, and therefore they want to know what is causing it. Before I forget, there are two other things which have been clearly shown to have an increase, a relationship to increase in ASD. One is exposure to SSRIs in utero. It doubles the likelihood of ASD in the child. The second is exposure to sodium valproate in utero. So these are psychotropic agents we use routinely. We used to assume that there was no risk in when pregnant women are given SSRIs. But more recently, we've developed the understanding that there is a doubling of risk. Now, these screening tools are very vary in terms of sensitivity and specificity. So, for example, MCHAT is quite a commonly used tool. It consists of 18 items, and the parent can complete it, or someone who knows the child can complete it. And there are various ones. This is just for screening. In terms of diagnosis itself, what would be recommended would be that you have to have a very early history. You need to be certain that the symptoms are present both in terms of the parental report as well as school or peer interaction. And it needs to be observed in multiple situations, because in one situation, if someone is extremely anxious, the person might come across as being socially abnormal at that time. So the gold standard still remains the autism diagnostic interview schedule, and then you've got the autism diagnostic observation schedule, which is actually an interaction with the child, which then you see whether you actually can elicit the symptoms that would be considered hallmark of the problem. And then you've got, these are the sort of questionnaire-based things with varying sort of issues around using it. But in a nutshell, autism or autism spectrum disorders can easily be, the diagnosis can be made as long as you go through a structured process and you take various aspects into account which lead to the effect on peer interactions. Now, coming to comorbidity, how does one understand what should be considered comorbidity in the context of ASD? First of all, there's a variety of arguments whether we call it comorbidity at all. Do we call it coexisting disorders? Do we call it co-occurring disorders? There are lots of pros and cons for it. But the sort of rules that you have to have is that if you want to make a diagnosis of two conditions together, the core domain of each disorder should be present. You cannot end up making a diagnosis of something like ASD if you don't have the social communication component problem present in that. The symptoms should reach the same threshold. Even if you have 5 disorders, each of those disorders should meet the same threshold like if someone had just one condition. And the most important thing is that symptoms should not be double counted. This is, for example, if you have someone with bipolar disorder and ADHD, you can't end up using the hyperactivity to be made to tick box for both ADHD as well as bipolar disorder. So therefore, you can't double count. And then you should have separate impairment. So if you have ADHD and ASD, you should be in a position to show that ADHD symptoms are producing a problem in disinhibition in class, for example, and the ASD is producing social communication difficulties leading to social cues which are being misinterpreted. Now, if you can demonstrate those two things, then you know that these two conditions are separate. And of course, developmentally, it should be inappropriate as such. And then sometimes, of course, for example, if you've developed depression, depression might develop at 12 years of age, while ADHD might be present by the time you're 3. So you have a development. So these are the sort of constructs which you have to understand when you're trying to make a true diagnosis of two different conditions together. If you're looking at the overview of what are the kinds of comorbidity that would be associated difficulties, you'd have medical conditions here, like sensory the issues, constipation, seizure disorder, and so on. You have behavioral comorbidities, which is basically anxiety, aggression, that's oppositional defiant disorder, and so on. And then you have the sort of cognitive impairments, comorbidities, which is to do with language and motor difficulties, intellectual disabilities, so on. You have genetic components where you can end up having a specific abnormality, let's say Fragile X, and so on. And then, of course, you have the biomarkers which are present in many individuals. So here you have the core features of the spectrum which you would have overlap with, and so this is basically, you have restrictive behaviors and you have the social communication aspects together. Now, this is a study that we did looking at hyperkinetic disorder or ADHD combined. And what we did was we looked at over 7,000 individuals who are from a population study. And what we did was we looked at those who had normal, these were the normal individuals, these are the individuals with hyperkinetic disorder or ADHD combined. This is the individuals with ASD, and this is the group with both ASD and ADHD together. And so what you can see is that social communication difficulties are higher even in those who do not have ASD. Just having hyperkinetic disorder means that you have more social impairment. And then here, this is the repetitive behaviors, exactly the same thing, more means more. But this is interesting that in terms of the language skills, it seems that if you have both conditions together, that's ADHD plus the ASD together, they seem to speak more. And when we explored it further, what we found was that it was because of the disinhibition which the ADHD brings, the impulsivity. It means that they seem to use all the language that they have. So it's not that it's an advantage, it just means that they are more disinhibited, so therefore they utilize more of the language, which then makes them appear to be more functional verbally. And so that's the only thing that is relevant with respect to that. Now, the other thing that we looked at was to see when it comes to psychosocial index, what we found was that in terms of the normal controls and ASD, there was no difference. But when it came to ADHD, they had far more psychosocial stressors and factors compared to even the combined. So pure ADHD appears more having psychosocial sort of influences, while on the other hand, when we looked at the neurological index, that's more biological in terms, it is just the opposite. And ASD seems to be significantly driven by biological factors, while ADHD, there's at least a significant component which is psychosocial. Now, this is, if nothing else to remember, this would be something that I would say is easy to remember. If you have someone with ADHD and they also are clumsy, there's a 15-fold increase in terms of the likelihood of that person also having ASD. So it's very simple to do. Someone with ADHD, they're clumsy, they have motor coordination difficulty. If you were to screen that person, you are very, very likely to see that that person also has ASD. Now, how do we manage these conditions? So there are some specific issues to do with medication when it comes to ASD. There are many individuals who are very specific as to what taste they will accept, what color they will accept, what shape they will accept. So we have to tailor-make the treatment to the patient because they have cognitive rigidity by which they refuse to take anything other than a white tablet. So if you end up having a tablet that is actually blue in color, they will not touch it. So you have to actually understand the rigidity of their thing and then actually look at that. And the most important thing is that low doses are essential rather than high doses, and you have to actually increase it very slowly, keep measuring outcomes regularly. And this is also important, that is, true informed consent is essential when you are dealing with co-occurring disorders, because you truly do not have very much evidence base out there to say clearly that this is what you would expect to happen to that particular patient. Having a true informed consent allows you to actually get better outcomes. Now, this is the age-old thing about how brain circuitry and neuromodulators are considered to be working and related in terms of the sort of neurotransmitters on this side and what in terms of the circuitry as such. Now, this would be the sort of applications, neurobiological applications you'd be looking at when you're looking at a system like a reward paradigm, and then you'd be looking at what is the driving and what is the brake in a very, very simple term, and trying to understand what are the kinds of medication or non-medication strategies that you'd be wanting to use. Now, when it comes to managing aggression or challenging behavior or irritability in this group of individuals with ASD, There are many studies which show that risperidone in low doses helps improve aggression or challenging behavior in ASD. Now, the issue is that if you were to incorporate along with risperidone, you also include a parenting program. That means you can reduce the total dosage of risperidone by roughly 25%, and you get similar improvement with a lower dose of the antipsychotic. The mean dose of risperidone for treating aggression in ASD is between 1.25 milligram a day and 1.75 milligram a day. It is not, doses above 2 milligram rarely make a difference other than just increasing side effects. So it's a low dose that you'd be actually using. Now, when it comes to aripiprazole, it's very similar. It produces quite significant improvement in challenging behavior, and again, it's low dose as such. So in these trials, they've not used doses less than 5 milligram, but 5 milligram is just as good as 10 or 15. But the thing is that you ended up with more side effects, and so actually the mean dose of aripiprazole in my clinic is 2 milligram. That's all we need to use, and it actually makes quite a significant difference. Now, mood stabilizers in ASD. You have one study which actually looks at sodium valproate, suggesting that it actually does help. There are just case reports of lamotrigine, carbamazepine, and so on. And so this is trying to put it in a slightly different way. What are the effect sizes? And you can see risperidone, aripiprazole has got quite decent effect sizes of around 0.8, 0.9. And there are other medicines like N-acetylcysteine, which has got effect size of around 0.7. And you can see this is the number needed to harm, the kind of side effects that you expect to see. And you can see weight gain is really the biggest issue with risperidone in this population. And there are some studies suggesting that the weight gain is more of a problem when you've got individuals who eat very specific foods. There are many individuals with ASD who will only eat certain foods and do not have a whole variety of foods as such. So, if you're talking about someone with aggression, someone with, say, oppositional defiant disorder, you will need to be incorporating strategies which are modified cognitive behavior therapy strategies, especially in parent training with modification. But in this, what is different about this particular subgroup is you have to focus on affect recognition, misattribution, because these are the core features which actually lead to misinterpretation and problems. And then, of course, affect regulation is an issue in this group. And then, of course, you can use the medications which you've suggested already. Now, coming to serotonergic drugs in this particular group, there was initially in '96, the first publication that came out was about fluoxamine in adults who had been deprived of tryptophan initially, and then they showed that in an adult population of 15 individuals with ASD, their symptoms of ASD got worse. And then after it got worse, they introduced fluoxamine and showed that within 2 weeks, the symptoms got better back to what it was. And therefore, they were clear that there was a serotonergic basis to this. However, we've got meta-analysis actually looking at the fact that SSRIs do not make any difference to restrictive and cognitive rigidity that is present in ASD as such. So if you're using an SSRI, you need to use it for the right reason, and that would be severe depression, anxiety, as such. But the side effect to remember in this group is that almost 1 in 2 to 1 in 3 individuals develop behavioral activation, which means that they suddenly start becoming excitable, running around, and you might wrongly diagnose them as having bipolar disorder, because all you have to do is reduce the dosage or introduce something like propranolol, and they will get better. Now, in terms of the mood and anxiety states, if you've got depression, then you have to try and do some modified cognitive behavior therapy if they are able to engage in it, The most important thing with cognitive behavior therapy is that you need much more sessions. The sessions have to be shorter. The sessions can't be more than 20 minutes, and you have to use a lot more visual based timetabling, and you have to use scientific methods of homework. So you actually ask them to go home and do a web based analysis, come up with an understanding as to why something is happening or not. You cannot ask them to generate their own thoughts to substitute something and make the connection between action, thoughts and behavior as such. Now, in terms of anxiety disorders, there is one aspect which is to do with the, in terms of treatment, which is very often these individuals are very highly hyper responsive to internal states. So if their heart rate changes, they become very distressed because it is very, very distressing internally for them. So in those instances, we end up using beta blockers like propranolol to help them with it. And if it's more cognitive, you use the cognitive behavior therapy, or you can use SSRIs as such. Insomnia, very simply, a significant number of them have insomnia related to anxiety. You have to treat the anxiety. In fact, more than 70% of them are anxious just before falling asleep. And so if you use sleep hygiene techniques and use modified CBT techniques, you actually can treat them.